Right. Is it okay if you can call, if I can call you back? I have a webinar that's about to start very soon.
Please record your message. When you've finished recording, you may hang up or press 1 for more options.
Hello?
Geller's 24. I'm having issues.
Hi, everyone. This is Amy Geller. We're just going to wait a few more minutes to let other people join. Hi again, everyone. This is Amy Geller. I am a study director here in the Health and Medicine Division of the National Academies of Sciences, Engineering, and Medicine. I think we'll get started. We're really excited to be kicking off the DC Public Health Case Challenge 2019 today. My colleagues Alina Bachu and Sophie Yang, also in the Health and Medicine Division, and I are joining you today. The purpose of this webinar is to ground all of you who represent so many different disciplines in some important tenets of public health and population health, and to provide some logistics, best practices, and lessons learned from over the years. And then at the end, we'll introduce the challenge to you for this year. I wanted to let you know that this presentation will be posted to the project website that Sophie will send you after the webinar today. It might take us about an hour or so, but we will send you the link once that's up. At the end of the webinar, Sophie will also be sending you the case and the challenge for this year and some other supporting documents that we'll talk about today on the webinar. It is now my pleasure to introduce Alina Bachu, who is a Senior Program Officer here at the National Academies and also directs the Roundtable on Population Health Improvement who will be giving you an overview of those important public health tenets that I was talking about. And you can see the slides on your screen. So Lena, you will need to unmute yourself before you get started.
Hear me?
Yes, we can hear you now. Great.
Good. Hi, everyone. Thanks so much for joining me and Amy and Sophie today. And I'm just going to share a few slides that provide some background that's going to be familiar to some of you, hopefully many of you, and for those of you who are not super familiar with these concepts, it'll hopefully help to sort of even the playing field a bit. Here's a definition of population health from Kindig and Stoddard, 2003. Population health is a concept in a field of study that combines the definition of measurement of health outcomes and their distribution, the patterns of determinants that influence such outcomes, and the policies that influence the optimal balance of determinants. And this is a definition that informs the work of the Roundtable on Population Health Improvement, but also other activities that happen in the Health Medicine Division and in the National Academy of Medicine here at the academies. Here's one simple way to try to depict the relationship between those patterns that we just heard about, health outcomes, and policies and interventions that help to shape them. And we'll talk a little bit later about the types of interventions and actions that can help shift the patterns of determinants and the health outcomes themselves. I think most of you know quite a bit about the state of population health in this country, that we spend a lot more on healthcare than any other country on earth, including all of our peer nations, wealthy industrialized countries with highly developed healthcare sectors. And we also know that there are significant and longstanding disparities in most health outcomes by education, race, and other categories. We know that many people in this country don't receive health care when they need it. They get it too late, and there are problems with the quality of the care that they receive. But we also know that health care is just one of many factors that shape health, despite the fact that the majority of our healthcare expenditures are in personal health services. So we have this misalignment that has been highlighted in previous reports from the academies, especially in an IOM report from 2012 that showed how completely out of whack our spending is with our performance on health as a nation. As I think most of you know, we tend to hover around the 30 to 40 rank compared to other nations. And here's one graphic from the OECD, the Organization for Economic Cooperation in Europe. I'm forgetting the exact words of the acronym. At any rate, if you look in here, you'll see that the United States is actually below where the OECD average is in terms of the life expectancy that we get. And if you put that, you juxtapose that with our spending, it really shows you how completely out of whack our country is in terms of how much we spend on health, largely on health care, and what we actually are able to achieve. Over the past century or so, there's been a strong trend towards medicalization of health, and health is generally viewed at the individual level through a biomedical lens, but we are learning more and more that health is not merely the result of health care, and health is certainly not equal to health care, despite the fact that those two terms are so often conflated. And the result of this is we have a myopic public policy focus on healthcare interventions. But I would say that we are seeing some encouraging signs. We know that the Centers for Medicare and Medicaid Services have really turned their attention over the last several years to addressing health-related social needs. And we're seeing more and more hospitals and health systems begin to ask questions about, screen for, refer for the other needs that patients have, which the medical establishment has come to recognize have implications for their health. But those health-related social needs are really just the basic or introductory level of considering the array of factors that shape health. So sometimes when I talk about the difference between health-related social needs and the social determinants of health, I describe health-related social needs as the ground level in a tall structure that's called the social determinants of health. So as I talk about on the next slide, just because a healthcare provider or hospital is referring food insecure people to a food bank, that doesn't mean that they're actually tackling the social determinants of health, because they're not changing economic policy to prevent food insecurity at the macro level, or working to change the food environment in the community. Although those are all areas that the health sector can conduct some advocacy around, can partner with others to help move the needle on those things. So obviously the roles and responsibilities on who's going to move the needle on these types of actions related to the social determinants of health doesn't just reside in healthcare, and actually a great deal of it resides outside of the healthcare delivery sector. The World Health Organization has defined the social determinants of health in a way that you have seen in many places, that is also echoed by the Culture of Health work from the Robert Wood Johnson Foundation and other places. So the social determinants of health are the circumstances in which people are born, grow up, live, work, and age, as well as the systems put in place to deal with their health status or illness. These circumstances are in turn shaped by a wider set of forces: economics, social policies, and politics.
Oh, I know. Did you give me that? Maybe.
Sorry, Sophie, would you mind muting? And I'm going to share a couple of pretty familiar graphics that you'll see in lots of different places, including National Academy's publications. There are many ways to depict the determinants of health, or more accurately, the factors that shape health, or the influences on health, since some have correctly objected to the term determinants as carrying sort of deterministic connotations and suggesting that there's an immutability to them, which is certainly not the case with most of the factors that shape health outcomes. We used to think that genetics, for example, was completely in the immutable category, actually, but we have seen a bit of a change with that recently. At any rate, you can see that this graphic and this other graphic depict concentric circles with the individual and the attributes associated with the individual at the center, and with interpersonal, institutional, community, and the highest level of sort of public policy factors at the outermost concentric circle. So we have seen from these depictions of what we've learned from the evidence that has been building up over the last several decades, that health is influenced by many factors at multiple levels of society, which include intrapersonal, interpersonal, institutional, community, and public policy. And those are all important to keep in mind, both for thinking about who plays what role, who has what capabilities, but also to think about the possible locus for interventions. Because there are many different areas where we could intervene and help to change the outcomes. And with many health outcomes and the inequitable distribution of those outcomes, we need to act on multiple levels. But the important thing to remember is that merely acting at the intrapersonal or interpersonal factors, so providing food or referrals for a food bank or other related supports to people in a healthcare setting, for example, or providing free lunch in a school setting, is really not the same as changing the conditions at a societal level, providing, for example, earned income tax credits or other very high-level macro changes that will help improve people's economic stability and therefore address food insecurity in a much more root causes oriented manner. So the social ecological model that we just discussed, and I should have said that I think the original person who came up with this concept of the social ecological model was outside of the health sector. It was someone named Bronfenbrenner. And I actually meant to make a slide on that, but I forgot. So I'm happy to share a resource on that if people are interested, though. So the model focuses on a broad array of social factors that create or produce health and health disparities. And we know that those disparities are produced at many levels, and that interventions need to occur at many levels, not just in the clinical setting, as I already mentioned. And prevention happens upstream. And of course, those of you who work in the healthcare sector, who are training in that space right now, know that there are different ways to talk about prevention, that there's primary prevention, secondary prevention, and tertiary prevention, and that there's a sense in which it's generally never too late to act, but public health science tells us that acting earlier and at a population level is the most efficient and the most effective way to do it. And to give you another sort of random example, preventing obesity at a population level by creating the conditions for people to engage in the kind of life choices that will ensure that their weight stays in the normal range is much more efficient and effective compared to doing bariatric surgery after people have already developed morbid obesity and all of the negative health outcomes associated with that. So a bit on primary prevention and secondary prevention. And I think you're all quite familiar with this. So I just provide a couple of examples here. Primary prevention, tobacco policies are one example of that. For example, banning smoking in workplaces or in restaurants or in bars. Educational attainment and the national and state level policies that make that possible are another example of that. Providing adequate financing for public education, for example. Preventing early exposures to trauma through a variety of strategies that involve policy changes is another example of primary prevention. And examples of secondary prevention would be delaying the onset of smoking, preventing progression of preeclampsia through regular and timely prenatal care in the case of maternal health, and providing clinical supports for addressing obesity once that is observed in a clinical setting. And here's a definition of policy that gives you a sense of the fact that it's a range. It's not just a single thing. Policy is a definite course or method of action or inaction selected by a government institution, group, or individual from among alternatives and in light of given conditions to guide and usually to determine present and future decisions. So any number of current conditions in this country, negative or positive, have been put into motion by policies that were enacted either recently or a very long time ago. So if any of you have been following the 1619 project from the New York Times, you may have learned or been reminded about the fact that Jim Crow laws in this country set into motion a set of circumstances that continue to this day. And it's not simply the legacy of those, but also policies that have continued to ripple through time and updated versions of those policies that have been segregationist in nature, for example, and have led to some of the really deep, profound health inequities that we are seeing, and the range of structural factors that lead to those unjust outcomes. Just a simple typology on policy, you'll hear people talk about big P, little p. Paula Lantz, who used to be a member of the Roundtable on Population Health Improvement, is probably one of the best people to talk about big P and little p. And she used to be at George Washington University. Some of you may know her or know of her. Big P is basically referring to laws and regulations, court rulings, administrative rules, etc., at the level of government, be it the federal government, the state government, or local government. There are generally consequences for breaking those laws or not following those regulations. So in almost all cases, these are enforceable. Sometimes, you know, they could be a bit of a paper tiger, but often there are strong enforcement options available for decision makers. And they also tend to have impact on large numbers. So when I was talking earlier about the efficiency of acting at the population level, that can have positive effects if it's used to improve public health and well-being and other positive types of outcomes. It could also have a very negative effect if it is set in place to disadvantage specific kinds of people. Policy with a little p is a type of categories of policy that are smaller in scope and less formal. This may be guidelines or policy statements from professional associations and recommendations of expert panels, but these could also be policies or rules within institutions or companies. When a company, for example, decides that it's going to provide certain kinds of policies to support working parents, for example, such as paid parental leave, federal law, as many of you know, only requires that a certain amount of unpaid leave be provided and that certain arrangements be made to preserve that person's job, but there is no requirement for paid leave. Employers may choose to do so because they believe it will improve the productivity, you know, commitment, et cetera, of their workers. So that's an example of policy with a little p, lowercase p. And local programs, capacity building activities, and other types of sort of lower level policies exist, and some of these come into play when we're trying to improve population health. Unfortunately, there are weak or no consequences for not following these, but we do see some promising examples sometimes in the private sector where little p policies can help build a groundswell for certain kinds of changes. So policy is both a cause of structural determinants of health inequities, like regressive taxation, for example, or residential segregation, or lax regulatory regimes. And the most powerful way to intervene and to thwart negative pathways at population level is also offered by policy. So for every policy intervention idea that you might consider, if you consider some of those in devising your solutions, give some thought to the type of policy it is and what its intent is. Think about what the logic and the evidence base behind it is, and the state of the evidence base, and understand the pathway by which it is believed that that policy intervention will help to improve health. And I'd say that the bottom line is that the more upstream the policy is focused, the more likely it is to help prevent negative health outcomes and disparities. And I have a couple of slides that are just sort of summarizing briefly what I mentioned earlier. Social disparities in health are produced over the life course from causes that occur at multiple levels, from within individuals to the highest level of policy that shape our environment at a very, very high level. And interventions aimed at preventing and reducing those disparities are needed at those very same levels. And the levels, just as a reminder, interpersonal, interpersonal, institutional, community, and finally, public policy. And I would just end with encouraging you to keep in mind the importance of thinking upstream as you consider the solutions, to not merely focus on the types of interventions that are clinical and most proximate to the patient or individual community resident level, but also to think about midstream and especially upstream level interventions. And just as a reminder, upstream is population level, primary prevention oriented, addressing root causes, and addressing systems change. And that's it. Any questions?
Hi, this is Amy. If you have a question, you can go ahead and type your question into the chat box. So if you don't see the chat box, on the bottom of your screen on Zoom, there's a number of buttons, and one of them says chat. If you click that, a box will pop up and you can type in a question, and then I'll read it and Alina will respond. There'll be an opportunity to ask Alina questions at the end, or all of us questions at the end also, if you think of something after we move on. So we're just going to wait a minute to see if anyone has any questions, give you a chance to type. And then if there's no questions, we'll move on. Okay, if you think of any questions during the rest of the webinar related to any part of it or any part of the case challenge, feel free to enter those at any time. So now, this is Amy again. I will be giving you an overview of some logistics and then some best practices. We will also be sending you this information in a Word document when we send the case after this webinar. However, we found it is helpful for folks to hear it as well as read it, especially since there are a lot of materials being sent to you, and we want to highlight some of the main items to make sure that you don't miss them. So first of all, this is very important that check-in with your presentation is due by 8:30 a.m. on October 18th, so the day of the event. You may email it. You can bring it on a flash drive the day of the event, however you want to do it, but we must have it by 8:30. The case has Sophie's email. The document I'm going to send you with these best practices has Sophie's email. You can copy Alina and I as well, but the most important person here is Sophie. Either way, whether you send the PowerPoint ahead of time or you bring it on a flash drive, be sure to check in with Sophie at the computer in room 25 when you arrive so that you can randomly select your team's number. So we have the universities go in whatever order that they selected out of a, not a hat, a box. And once you have your number, we'll give you a folder that has that number on it so you will not forget. And then when it's your turn to present, you will come in at that time. So if you're team number 1, you will be in the room already after the opening remarks, and then you will come up to the front and present. At that time, we will ask the rest of the teams to leave the room and wait in the holding area, which is the West Court or anywhere else in the building, so that after you present, you can then stay in the room. So you cannot watch other people's presentations because it gives an unfair advantage to you to hear the types of questions the judges will be asking. So once you present, you can stay in the room or not, but until you present, you cannot stay in the auditorium. However, we will all start in the auditorium. There'll be some introductory remarks by Dr. Victor Zhao, the president of the National Academy of Medicine. And at that point, when team 1 begins, we will ask the other teams to leave. Judges will have a copy of your slides during the presentation. It is absolutely acceptable to provide additional materials to the judges that expand on your presentation. For example, this could be appendix slides to your presentation proper that you don't present but have handy to refer to during Q&A, or for the judges to refer to during their deliberations. And I can tell you from experience from the past 6 years, the judges do refer to your slides, including your appendix slides, as they deliberate. For example, that would be a good place to keep a more detailed version of your budget. Or you may provide an example or a mock-up of a brochure or guide or other materials that you would be using during your solution or intervention. So the judging rubric is available in the case packet. I encourage you to look at it to see the types of things the judges will be looking for. The case writing team, so the students at your universities that wrote the case, will be available, and us, staff, will be available and will accept questions via email until 9 a.m. on October 17th. When we receive a question, if it's for the case writers, we will send it to them. And then when they send the response, we will send that to all of the case challenge participants to make sure everyone is working with the same information. So any questions you ask us, we will share with all the other teams. And this can include anything to clarify logistics as well, or something in the case itself. So we will be providing breakfast and lunch. Breakfast will be right outside the room where the competition is taking place, and lunch will be in the West Court. We'll have all this information for you the day of and plenty of staff on hand to help you find all of these rooms. The agenda is at the end of the case challenge packet. You will see that teams have 15 minutes to present their solution with 10 minutes for Q&A. Judges then have 5 minutes to take some notes, fill out the judging rubric, while the next team gets ready at the front of the room. I should add that there is no stage in this room. For any of you who participated in the years where we've held this in the auditorium, the setup is different. It's just a regular room where the teams will present at the front, and there'll be a panel of judges sitting in front of you who, and then the audience will be behind that. There will be a podium and 2 handheld mics for you to use. The podium also has a microphone. It's completely up to you if you would like to stand in the front or if you'd all like to use the podium or however you want to do that. But do keep in mind as you're rehearsing that there are only 2 handheld mics, and so you may need to pass between yourselves during the presentation. There'll also be a clicker to advance your slides, so you'll be advancing them yourself. And there is a laser pointer on there should you need it. We will also be taking team photos by a professional photographer between 9:30 and 10:30. Staff will help escort you, and we'll let you know the order of the teams and when to be where when at the day of the event. Let's see. Oh, and also if you arrive early that day, feel free to check out the space in 125 to figure out where you're going to stand, you know, take a look at the space. That's during the presentations, like I said, you could enjoy some more breakfast outside of the room, or we have a nice room, the West Court, available for you to sit. The building is also very beautiful. It's a historic building, and there's lots of interesting things to see and some art, so you can also take the time to look at that. After all the teams present, we'll break for lunch. You'll have some time to just relax, talk to your teammates, students from the other school, and just take a deep breath. We will then probably have an icebreaker or 2, and then at 2:30, Dr. Marcia McNutt, who is the president of the National Academy of Sciences, will be giving a talk to you. She's going to talk about the importance of interdisciplinary work and how that looks in the real world, and then she'll also there'll be an opportunity to also have Q&A with her. This is a really great opportunity to hear from and ask questions of a leader of the field. She's really wonderful. During that time, the judges will be deliberating. After they're done deliberating, we will reconvene in the West Court where the judges will be providing the awards. And at that time, oh, this is really important. I didn't mention this at the beginning. The judges will not know the identity of the team. So please do not, when you give your presentation, say what school you're from. You are welcome to introduce yourself, give your name, your area of study if you'd like. However, do not wear anything that would give away your university or say your university. So after the judges deliberate at that time, when we all reconvene in the West Court, we will ask each team to stand up and say what university they're from and what discipline they present. After we give the awards, we want to make sure that we get a photo with everyone and the judges, so please don't disperse. Wait a few minutes. We're gonna, right there in the West Court, all get together, have a group photo, so please stick around for that. Also, the winning teams will need to fill out some paperwork for us so we can get you the prize money. So we'll ask you at that time to see Sophie to take care of that. So that's all in terms of logistics. I know that was a lot. This information is also in the guide that you will receive, or the case challenge packet that you will receive today after the webinar. So if you missed any of that, don't worry, it's pretty much all there. Okay, so now I'm going to get into some guidance. So this is based on our years of experience. We always are sitting in as the judges deliberate, and so here are the types of things that they talk about. So we're wanting to share some of that information with you so that each year the presentations can get better and better. So first of all, interpreting the evidence to produce a meaningful and relevant solution. So be sure to ground your presentation in the available evidence, but don't rely on literature-based rationale alone. Think about the evidence or rationale that what you're proposing will work in the particular context. So in this case, in the DC community that you're focusing on, especially if a model was developed for a different purpose or community or population. Think about the assumptions you're making. You know, what is your logic model or theory of change? How is what you're doing going to produce that change? And be sure to share that in your presentation. Think about how circumstances might differ from what has already been studied and evaluated, and how you'll address those uncertainties. And think about what existing local programs or resources your solution can build off of. So also, getting at what Alina was presenting about earlier, be sure to think through the root or underlying causes of the problem that you're being asked to solve, and be sure those are considered in your solution, and that you're addressing some of the problems downstream, so those root causes, because only addressing those downstream causes, as Alina said, won't prevent it from happening again in the future. So you're welcome to engage with the community who will be impacted or participate in your solution. So this can be a way to learn about what some of the actual real life barriers are for folks, or, you know, is this something that would be accepted? You know, is this something that folks would be interested in taking part in? So you can talk to people that would help you understand, you know, the perspective of those you're trying to help. And work with hand in hand. And, you know, this is actually, can be a critical part of your rationale as you do your presentation. So be sure to share any information that you glean from that work with the judges. One caution, however, it's really important when you do reach out to stakeholders, whether it be community organizations or community members, that you're very clear why you're doing that. You need to let them know that you are part of this case challenge and that you're representing your university. In the document we're sending, I provided some example language that you could use either on a phone call or in an email when you're reaching out to someone, so that you can be sure that they know, for example, that this isn't something that will actually happen. You know, this isn't real money that will be invested in the community, but that this is a really critical learning experience for folks who will be actually using real money in the future once you've graduated. Another caution is to keep in mind that other university teams may be contacting these same individuals, you know, depending on who it is. And so keep in mind that these are busy people who are working really hard, and please be respectful of their time. Okay, evaluation, don't forget about it. In past years, teams haven't given it due attention, and the judges have definitely noticed, and the team scores were diminished because of it. So think about it strategically. Think about it from the beginning as you're planning your solution. What are you going to do? What methods are you going to use? What's your evaluation process going to be? What types of data could you collect or might you want to collect? This is a great area to talk to your advisor and get feedback. So they can't tell you what to do in your evaluation plan. That would be against the rules. However, they can provide feedback on feasibility or ask you really good questions to think about that are relevant to your solution. They surely have lots of experience in this area, and I know this is an area where students may not yet have a lot of experience, but it's very important. We provided a resource from CDC. It's very long. I wouldn't expect you to read it. It's over 100 pages, but it does get into, for example, some methods or the process of evaluation that might be a good resource for you to refer to. And be prepared to answer questions on your evaluation plan. Almost every year for every team, judges ask questions on it. They want to know more information. They want you to expand. So I'm not saying you need to take up more of the time than you would have allotted from your 15-minute presentation, but do be prepared to meaningfully answer the questions about evaluation to show that you've given it a lot of thought and that it's feasible and actionable, and know how you will then use that information from your evaluation plan to better improve your intervention. So this is the last section. So when you're presenting your solution, early on, give your audience a 1 to 2 sentence elevator speech. You know, something memorable that will provide the foundation for what you're about to present, so that it's really clear upfront that you have a clear purpose and a clear vision of what your solution is going to be. Describe, you know, what the intervention will look like on the ground, so that help the judges visualize what it'll look like in action. Show that you understand the evidence and understand the community during your presentation. Anticipate potential barriers and discuss those during your presentation. You know, sort of heed off some questions from the judges by letting them know you've thought this through. You've thought through what might some of the issues be and how you will address them. Think about your budget. Don't forget about that either. A good rule of thumb in public health is that evaluation should be about 10% of your budget. So think about that again from the beginning. And then, oh, sorry, that wasn't the last section. One more section is on presentation delivery. So this gets at that sort of elevator 1 to 2 sentence speech. Don't bury the lead. Don't rush through your presentation. If you rush, key pieces of information can be missed, and it could seem like you couldn't narrow down and focus on the key and essential information, right? The judges want to see that you know what are the most important things to present, and that you're not just trying to cram in every single thought. Pause for a moment after really key, important statements so that they can sink in. Stand behind your case. Don't lead any responses with apologies. You know, be confident during Q&A. Take a moment to pause and reflect before you respond if needed. But, you know, if the judges didn't seem to understand something you presented, again, don't apologize for it. Explain it. Help them understand. And plan your transitions in advance, both in terms of the slides and the verbal presentation. The flow can really make or break, in some cases, a presentation. So that is the end of my overview of the best practices. And I know I said don't speak too fast during your presentation, and I just did. However, because I want to leave time for Q&A, however, like I said, all of this will be sent to you in a Word document for you to refer back to, or a PDF, but you know, you'll have all of this. So now I'm just quickly going to present to you the problem that we're asking you all to address this year. So the case writing team worked really hard on the case for this year and the problem they want you to address. And so I'm going to share that with you right now. So as background, as some of you may be aware, there are approximately 700 pregnancy-related deaths in the US each year, with disproportionately high rates among low-income women and women of color. So this is one of those facts that I want to really sink in with you, this next one. DC has the highest total maternity mortality ratio in the nation, with almost 49 pregnancy-related deaths per 100,000 live births from 2005 to 2014. If you compare that to the national number, it's set approximately 17 deaths per 100,000. So it's 49 per 100,000 in DC and 17 per 100,000 nationally. In that same time period from 2005 to 2014, the maternity mortality ratio for Black women in DC was about 70 pregnancy-related deaths per 100,000 live births. 70. If you compare that to white women in DC, it was 0. These stats are clearly unacceptable and should be among one of the highest priorities in DC. There are some new efforts underway that you'll read about in the case that we will be sending you, including a new maternal mortality review committee. However, more effort is needed and innovative solutions are necessary. The solutions must take into account all the factors that Alina was talking about. So the underlying factors and root causes of health disparities. So this includes social needs, such as income, housing, and also things like bias and discrimination, among others. So your challenge is to address the underlying causes of disparities in rates of maternal mortality and related morbidities for residents of DC. The focus is on addressing unmet health-related social needs. Also, given the great advance in the availability of and use of data and technologies such as artificial intelligence, among many others, one element of the solution, of your solution, should include the use, innovative use of data or technology. As I mentioned, Sophie will be emailing you the case shortly after this call. I'd say no later than 1:15. If you haven't received it by then, definitely send her an email. And the case has much more detail on what I just described. So now I would like to give you all the opportunity to ask questions. So this could be on Alina's presentation, on logistics, on the case, anything that comes to mind. I know that was a bit of information overload, so if you have questions after, again, you can feel free to email Sophie and we will get a response to you and all the other teams. So I see one question. It says, what's the allotted time for each presentation? So each team gets 15 minutes to present. While you're presenting, we will hold up a paper that is yellow when I believe you have 2 minutes left. And then, actually, I don't remember what we do, but we'll announce it the day of the event. But basically, we'll let you know when you have, I think, 5 minutes left, 2 minutes left, and then 30 seconds left. And then when your time is up at 15 minutes, we will cut you off. So even if you're in the middle of a sentence, we will obnoxiously have to stand up and say time so that all teams have exactly the same amount of time. And then that will be followed by 10 minutes of Q&A. So same thing, if the judge is in the middle of a question or you're in the middle of responding, we have to cut it off at exactly 10 minutes. So that's actually a good reason to be prepared for these questions and to have good, succinct responses to them so that you can get in more Q&A with the judges. Any other questions? Okay, well, then I think we can wrap up. We will, like I said, be posting this webinar to the website and we will send you that link so that if you have any teammates who are not available to listen in, they can listen in at a convenient time. Oh, I see, there's one more question. You mentioned a question about budget. Is that related to how much it costs to solve a problem in the DC area? Is it a set budget? So the budget is for $3 million over 5 years, and that's actually one of the largest budgets that has ever been given in the case challenge. There isn't a set amount how much a intervention may in general cost in DC. It depends on what you would do, your staffing levels, things like that. But you need to think creatively and innovatively with a $3 million total budget. And that includes, keep in mind, any money for staff allocation as well. Did that answer your question? Great. Okay, let me just make sure I didn't miss any other questions. I don't think so. Okay. Okay, so where can you access the judging rubric? So the judging rubric, everything regarding logistics for the case, the rules of the case challenge, and all of the background information that was written by the case writing team, including the judging rubric and the agenda, and a list of local relevant community organizations, is in the case challenge packet that Sophie will be sending out. So I think the judging rubric is one of the last appendices. But if you just search the document for rubric, you will find it. So you're going to be sent a few documents. You're going to be sent the case challenge itself. So that's the document with the challenge to you, the background information, the rules, guidelines, logistics. You will receive a document that's the overview of the logistics and the best practices I went over today. And then you'll also receive a one-pager that gives an overview of the case challenge, just a general overview for you to share with individuals who you may contact to glean or get information to inform your solution. I think that's everything we're sending you, but there may be one or two other things. So in general, is the general public allowed to join the event, or is it limited to only to participants? That's a great question, actually. I'm glad you asked that. So it's by invitation only, so it's not open to the general public, not just anyone could walk in. However, if you have a fellow student who you think might be interested in seeing this, or who might be interested in doing this in the future, who you think should see it, a faculty member you'd like to invite, a family member you'd like to invite, anything like that, let us know and we can arrange that. You know, we can't have probably more than 2 to 3 invites per student, or possibly only 1 to 2, but we're happy to have, you know, a few people join for the day. And you can reach out to us separately about that. That's obviously not the type of thing that we would then share with all the other teams. If you have someone you would like to invite, just email Sophie and we will get back to you. Okay, before I wrap up, I just want to see if Alina or Sophie have anything else to add. And that will also give 1 more minute to see if any other questions come in.
Can't think of anything that was omitted.
Great. Okay. Well, then I'm going to call this a wrap. Look for an email from Sophie in the next, it wouldn't be before 1 o'clock, but anywhere between 1 and 1:15. She's just wrapping up a few last details. And we look forward to seeing all of you at the event on the 18th. We're really excited. This is one of our favorite events, and we're, like I said, just really excited about it. So thank you very much for joining us, and good luck to all of the teams. Thank you.